Yes.
Thank you, sir. We pick up in 1990. November 1990, Dr. Napier prepared a set of recommendations for the Institute of Audit within the NBTS. For the reference, it's BCUH 5060, but we won't go to it. He indicated that hospital transfusion committees was to have a range of disciplines represented on it and was to focus on educational matters, audit and review, policy development, safety of transfusion and review of proficiency assessment performance. The educational function of those hospital transfusion committees included an awareness of national guidelines for the promotion of good transfusion practice, development of local hospital guidelines, transfusion policy induction procedures for new staff, review of nursing procedures for the administration of blood products, promotion of important new information regarding transfusion matters, and ensuring that patients are adequately informed of matters that may concern them. It was noted in his recommendations that hospital transfusion committees could have an overview function with regard to many of the above items, encouraging particular clinical departments to review and question the appropriateness of their own transfusion practices by a peer group pressure mechanism. He said there's good evidence to suppose that at least for certain blood products, a substantial proportion of usage does not accord with well-founded clinical guidelines. Making inroads into such areas of dubious use would contribute greatly to safety and economy. In November 1991, the British Committee for Standards in Haematology produced guidelines for the use of fresh frozen plasma. The introduction to those guidelines states that studies of the use of fresh frozen plasma have shown that it's often misused. This is largely due to the misconceptions regarding its hemostatic effectiveness and inadequate knowledge of the situations in which its use is inappropriate. In the UK, the number of units of FFP transfused during the past 15 years has increased greater than tenfold. Although FFP has been used in an increasingly wide range of clinical situations, in many instances there is no rational basis for its administration. And the guidelines note that there are few well-documented and universally accepted indications for the use of FFP. Those indications were limited to the treatment of bleeding episodes or preparation for surgery in patients with factor deficiencies, where the specific factor concentrates are unavailable. Following a concern that was raised by the Chief Medical Officer about the use of single-unit blood transfusions, in November 1991, Dr. Williams, Director of the Medical Care Research Unit of the University of Sheffield, produced a review for the Department of Health titled The Use of Single-Unit Blood Transfusion. Could we have that on screen, please, Sully? DHSC 20-25270. And if we turn straight to page 4, please. We see the heading, The Arguments. Single-unit transfusions of red cells are generally thought to be unwarranted, inasmuch as the oxygen-carrying enhancement they represent is marginal, except in certain circumstances, such as for small volume recipients and for the augmentation of an autologous transfusion, or where the quantity needed to produce a desired result is less than anticipated, or when the patient dies while the transfusion is progressing. In practice, where otherwise they do occur, they are assumed to be due to questionable clinical judgment about the need for top-up enhancements during or after surgery, particularly for the elderly, or about the need in obstetric cases. The extent of their use for non-surgical cases is not so well known, but again, it's commonly thought to be associated with the top-up philosophy. And then if we turn to page 5. Present state of knowledge. Our present state of knowledge of blood product transfusion practice in this country is incomplete and not accurately ascertainable using existing routine information systems. The National Blood Transfusion Service Directorate's Management Information System receives its datasets from regional blood transfusion services. These, in turn, describe only the nature and volumes of products donated, processed, and distributed to hospital blood banks. No routine data exist at regional level on transfusion practice in the institutions served, which would allow the incidence of single unit transfusions to be measured. Then if we turn to page 7, a final comment on the present state of knowledge is that transfusion strategy appears to be based almost entirely on clinical consensus based on wide experience over many years. Reports of clinical trials systematically organised with random allocation of patients to different types of transfusion intervention or non-intervention are rare. There are ethical issues involved in mounting such trials, particularly issues of safety, with possible attendant risks of transfusion or non-transfusion. If systematic auditing of the tariffs and schedules recommended for transfusion practice among our hospitals were to show moderate or wide degrees of variation, there might be scope for mounting comparative trials of similar but not identical transfusion practices, 2 units against 3, etc., the outcomes being measured both in technical terms, hematocrit, etc., and in terms of impact on overall health and well-being, health status profiles, etc. Neither the overall pattern of transfusion practice in this country nor any variations in it are at all well known. The issues of safety, effectiveness and resource conservation which are involved, along with the more stringent requirements imposed by recent legislation, imply that there may now be a need to know. And so the report then recommends further research on what the practice was in relation to transfusions in various specialties. During this time, a major study was ongoing involving Dr. Brian McClelland called the Sanguis study. This was a study that was being undertaken across Europe to produce a database of current surgical transfusion behaviour. The interim report noted that 60 to 80% of blood components were used in surgical procedures. 6 classes of procedure had been selected for audit across teaching hospitals in 10 countries, and the data showed a wide variation in use of red cells between the different hospitals in Great Britain for total hip replacement surgery, as well as a wide variation across Europe. In June 1992, we have another set of guidelines from the British Committee for Standards on Haematology, this time in relation to platelet transfusions. Could we turn to BSHA 5031, please? We see at the start the indication the use of platelet transfusions has risen considerably in recent years, mainly as a consequence of the increasingly intensive treatment of patients with haematological malignancies. And then under the heading Indications for Platelet Transfusions. Platelet transfusions are indicated for the prevention and treatment of hemorrhage in patients with thrombocytopenia or platelet function defects. Clinically, this may involve 1 or more transfusions for the treatment of a single incident or repeated transfusions over a period of time. And then under the heading bone marrow failure, platelet transfusions for patients who are bleeding. Platelet transfusions are established as effective treatment for patients with thrombocytopenic bleeding associated with bone marrow failure caused by disease. Cytotoxic therapy, just turn the page. Cytotoxic therapy or irradiation. Serious spontaneous hemorrhage due to thrombocytopenia alone is unlikely to occur at platelet counts above 10 to 20 times 10 to the 9. Minor bleeding, such as purpura and epistasis, may occur at platelet counts below 50 times 10 to the 9. Prophylactic platelet transfusions have been shown to decrease morbidity, although not mortality, in patients with thrombocytopenia due to bone marrow failure. And if we continue down, the use of platelet transfusions to keep the platelet count above 10 times 10 to the 9 reduces the risk of hemorrhage as effectively as keeping it above any higher level. A recent study showed that a further reduction in the threshold for prophylactic platelet transfusions may be possible. However, if factors associated with bleeding in thrombocytopenic patients are present, such as fever and infection, concurrent coagulopathy, a rapid fall in platelet count, or if there are potential bleeding sites as a result of surgery, the use of prophylactic platelet transfusions might be considered to keep the platelet count above 20 times 10 to the 9. An optimal policy for prophylactic platelet transfusions has not been defined, and the threshold platelet count should be based on an audit of local clinical practice. In relation to massive blood transfusion, the guidelines cross-refer to the guidelines for massive blood loss. In 1994, the second edition of the Red Book, Guidelines for the Blood Transfusion Services, were published. They contain no guidance on when a blood transfusion should be given, but it does contain a note that there should be an audit trail allowing traceability of a blood product from the patient to the donor. It notes that the key to traceability is the donation number. Can we then turn to DHSC 304486_097, please? We pick up here a meeting of the British Committee for Standards in Haematology, dated the 13th of July 1994. And at the bottom of this page, we see a note, consent for transfusion. It's the Blood Transfusion Task Force. The task force discussed the proposal at length. Written comments from members of the profession were considered. The following conclusions were reached. The risks associated with blood transfusion were not of such magnitude that there should be a legal requirement for informed consent to transfusion. 2, there is a clear ethical duty upon doctors to inform patient what is to be done to them, and this includes blood transfusion. The problem of transfusion given to patients under anaesthesia for elective conditions without their knowledge was particularly highlighted. The information leaflet was considered to be valuable and should be made available to patients upon request. The members of the task force felt that this was not an area where they could publish a guideline. It was felt that the information leaflet could be incorporated into the transfusion handbook, where it would provide a valuable data source for junior doctors. The question of incorporating consent for transfusion into the consent for operation in some way was felt to be a problem which this task force could not address, and which referred to good medical practice in surgical specialities, which should be addressed through either the respective royal colleges or perhaps by the Department of Health. The task force concluded that the information data should be incorporated into the transfusion handbook, but that no further action could be taken by this group in regard to the question of consent for transfusion. Then if we go on to NHBT 00593994, please.
Let's just go back to the page and up to the page we were on before.
Of course. DHSC 304486_097, please.
And the turn over the page. So I just try to understand how 1 and 2 fit together. First starts with 2, clear ethical duty upon doctors to inform patients what is to be done to them. But 1, the risks not of such magnitude that there should be a legal requirement for informed consent to transfusion. If the question here is negligence, clinical negligence, the general standard would be the standard which a doctor acting properly would adopt. Mm-hmm. If a doctor acting properly has a clear ethical duty, that's the standard, isn't it?
So I think the distinction may be the difference between informing the patient of what's to be done and obtaining consent for what is to be done.
So you can inform him that you're going to give him a transfusion and not ask him to consent to it?
That appears to be what the document is suggesting.
Which legally would mean effectively doing something to a patient which involves breaking the skin.
Indeed.
Putting substance into him. That's an assault unless there's consent, technically, isn't it?
Indeed, it's a very strange document, which is why I felt it was important that it was provided
Well,
today.
it just struck me, just as you were passing from the document, that there was a tension between the first 2 paragraphs.
There's a very clear tension between information and consent in these meeting minutes.
And this is...
And also that the information leaflet, if we just look at 3, the information leaflet's valuable, but only available to patients upon request.
Yes. And this is a task force of whom?
It is the task force, it's the Blood Transfusion Task Force for the British Committee for Standards in Haematology of the British Society of Haematology. All the guidelines that we've looked at from the British Society of Haematology have arisen from this committee for standards. Yes. So they've produced a large number of guidelines, which is why the minutes of this particular task force are of particular relevance.
Yes, thank you.
If we can then pick up the 1995 edition of the Handbook of Transfusion Medicine, NHBT 00599394. Because, sir, you'll recall that the meeting minutes indicated that the information leaflet would go into this handbook. So if we turn to page 25, please. We see the heading Procedures, Information for Patients, explain the proposed transfusion treatment to the patient or relatives and record in the case notes that you have done so. Patients or their relatives may be worried about the risks of transfusion. Some may wish to know more about the risks, about the need for transfusion, and about alternatives such as autologous transfusion or drugs such as erythropoietin. Patients of the Jehovah's Witness faith are strictly banned by their religious beliefs from receiving blood components, but may be prepared to accept plasma fractions or alternative treatments. Research has shown that patients often have no recollection of being informed about treatment options or feel that they have not had answers to questions about that worry them. The balance of legal opinion is that a written record that the patient has been given information and that his or her questions have been answered is more valuable in a medico-legal case than the patient's signature on a consent form. Answers to most patients' questions should be found in this book. We've also included an outline of an information sheet for patients on page, and it's not there. You should check if your hospital has a leaflet of this type and that your patients receive it. So this appears to be the implementation of that decision in the task force meeting. It might appear from this that there is clear guidance in relation to the information to be provided to patients, but no reference to expressly seeking consent.
Although it's implicit that if you happen to know that your patient is a Jehovah's Witness, that the Jehovah's Witness may have something to say about it.
Indeed.
And indeed, the suggestion implies, at any rate, there's a discussion on the basis that there is a right to say no thanks.
Indeed. But it's not explicit here that consent must be obtained.
No.
To give some indication of the practice on the ground, the inquiry has identified a Royal College of Physicians report in January 1998, their national audit of the clinical blood transfusion process, NHBT 0042247, please. If we turn to page 3, please. Background. Assessment of the quality assurance of blood transfusion pays little attention to the clinical interface. The British Committee for Standards in Haematology makes recommendations for good transfusion practice through its Blood Transfusion Task Force, and laboratory performance is monitored by the National External Quality Assurance Scheme for blood group serology. Then there's discussion of there having been a workshop in 1992 to try and establish the process and the audit that was taking place. And if we can turn to page 4. We see under the heading Audit that 53 haematologists initially expressed interest in the audit and 50 hospitals eventually took part. Most areas of England were represented and there were participants from Scotland, Wales and Northern Ireland. And then against Q1B, policies for the transfusion of blood on the wards existed in 89% of hospitals. These hospitals also had written policies for the administration of blood on the ward, and most included guidance on monitoring transfusion and advice about what to do if a transfusion reaction occurs. In 93% of hospitals, copies of the policy were available on all wards. Then in relation to hospital transfusion committees, in 79% of hospitals, there is a transfusion committee, and in 65% of these, audits of transfusion practice had been carried out. In all but one of these, recommendations on transfusion practice had been made based on results of the audits. Maximum surgical blood order schedule. This existed in 87% of hospitals, and in 71% of these, regular review is carried out. And if we turn to page 6, please. We see under Q5, informed consent. No hospitals required informed consent for blood transfusion. And then if we look at the bottom of the page, transfusion date and 2 signatures for each unit transfused. The transfusion date and 2 signatures were recorded for only 85% and 79% respectively of all units transfused, which of course goes to the question of traceability. Moving on to speciality-specific guidance in the 1990s. I want to turn first, as I did last time, to surgery. And if we go to NHBT 40104_027, please. We're picking up the Royal College of Surgeons course material in clinical surgery in general in 1993. And if we turn the page, we are in chapter 17, dealing with the correction of pre-operative, perioperative and post-operative anemia. And it starts in this way. The administration of blood and blood products represents substitution therapy and can correct almost immediately and invariably the existing anemia, thrombocytopenia, coagulopathy, or hyperproteinemia in the patient. However, the administration of blood and blood products is not without risk and should be carried out where the indications are clearly established, i.e., where the benefits to the patient outweigh the risks of transfusion. If we then pick up at the bottom of this page, ready to go over the page, the main objective in the management of anemia encountered in surgical practice is to ensure adequate oxygenation of tissues and particularly of the heart and the brain. Experience accumulated over the last few years has shown that that objective is achieved when the hemoglobin concentration is above 8 grams per decilitre. That level of hemoglobin at which a decision to transfuse the patient is usually made is generally known as the transfusion trigger. While the transfusion trigger can be useful as a pointer for action, it should never be used as an immutable value, as for example, a young patient with hemoglobin concentration substantially lower than 8 may tolerate the operation much better than an old patient with a higher hemoglobin level, but with a failing heart or compromised cerebral circulation. Just a little bit further down, although it's well documented that the level of hemoglobin and post-operative survival are inversely correlated, neither clinical observations nor laboratory experiments have been able to define the lowest safe hemoglobin concentration. Therefore, it is mandatory to assess each patient individually and to consider the type and probable duration of anaesthesia and of operation before a decision to administer blood is made. And then on the same page, under the heading Pre-Operative Anemia, the determination of hemoglobin concentration, part of the preoperative assessment of the patient, will reveal the presence of anemia, and then the figures are given. Faced with the anemic patient awaiting surgery, the surgeon should first ensure that the correct diagnosis of anemia is made, or at least that the samples required for the diagnosis have been collected. Second, he should decide whether to proceed with or defer the operation. Finally, he should decide whether the patient requires transfusion of blood. The decision to transfuse the patient should be based on the type and degree of anemia and the urgency for surgery. Elective surgery should be delayed until hemoglobin concentration is raised to the level considered safe for the patient. So that approach in the Guide on Surgery could be compared with the 1980s approach, which was perhaps more ready to transfuse rather than delay the surgery. With regard to hemoglobinopathies, the Secretary of State for Health invited the Standing Medical Advisory Committee to consider the care of patients with hemoglobinopathies and to report. The report was published in 1993 and recognised that the care of patients with hemoglobinopathies was not always of the highest quality, even where these disorders are frequently seen. Recommendations were made in relation to improving that care. Interestingly, there is no reference throughout the report to patients having been infected with hepatitis C or HIV by infected blood, and consequently, nor are there any recommendations in relation to their subsequent care and treatment. Guidelines for the administration of blood products in infants and neonates were published by the British Committee for Standards in Haematology in 1994. Although the guidelines acknowledge the difficulties of haemoglobin measurement, especially in any case associated with gestational age and prematurity changes, the guidelines recommend red cell transfusions should be considered for any symptomatic neonate whose haemoglobin concentration is less than 10.5. Neonates requiring supplemental oxygen should be maintained at a higher level. Prophylactic platelet transfusion is stated to be probably justified at platelet counts below 30 times 10 to the 9, or in the case of very sick and premature neonates, when counts fall below 50 times 10 to the 9, because thrombocytopenia is believed to be more hazardous in neonates. We move now to the 2000s. First of all, in my other file, NHBT 309569, please. we have another guideline from the British Committee, guidelines for the clinical use of red cell transfusions. We pick up the second paragraph. There is evidence of very significant variation in the use of red cell transfusions, for example, as provided by the Sanguis study, indicating that currently available guidelines have little impact on clinical practice. This variation does not correlate with patient characteristics, appearing to be more dependent on the individual clinician ordering the transfusion, strongly suggesting that inappropriate use is widespread. Several recent events in relation to blood transfusion in the UK support the view that renewed efforts should be made to encourage better use of red cell transfusions, and that includes renewed concerns about the safety of transfusion in light of some SHOT reports, the Serious Hazards of Transfusion Initiative reports, and the theoretical risk of transmission of variant CJD, is how they describe it, and new safety requirements such as leukocyte depletion and nucleic acid testing, increasing the cost. The guidelines then go on to consider parameters that to be used to indicate the need for red cell transfusions, picking up at the bottom of the column, acute anemia. Acute anemia is usually caused by blood loss, where the effects of anemia should be separated from those of hypervolemia. Clinical experience has shown that losses of up to 30 to 40% can be treated with crystalloids. And then we move to page 3, please. Can be treated with crystalloids alone in young, healthy patients. Acute isovolemic anemia to a hemoglobin concentration of around 5 grams per decilitre in a study of volunteers and patients produced no evidence of inadequate oxygenation. Recent studies have shown that a threshold for red cell transfusion of 8 grams per decilitre was as safe as one of 9 in patients undergoing coronary artery bypass surgery, and a threshold of 7 was as safe and possibly superior to a threshold of 10 in critically ill patients. And then on the other column, for many years, it was traditional to use a trigger of a hemoglobin concentration of 10 grams per decilitre for perioperative red cell transfusion and for transfusions to medical patients. However, there is evidence that renal transplant patients and Jehovah's Witnesses undergo surgery successfully with lower hemoglobin concentrations. And if we turn over the page, in the middle of the column, conclusions, there are no reliable parameters to guide the need for red cell transfusion. The decision to transfuse red cells is a complex one and depends on factors such as the cause of the anemia, its severity and chronicity, the patient's ability to compensate for anemia, the likelihood of further blood loss, and the need to provide some reserve before the onset of tissue hypoxia. The risks of transfusion also need to be balanced against the perceived benefits. Although guidelines for red cell transfusion often specify a given concentration of hemoglobin in order to be pragmatic, consideration of the patient's clinical condition is an essential part of the decision to transfuse red cells or not, and is a matter for clinical judgment. So you'll recall that earlier this afternoon I dealt with a document from CREST in Northern Ireland, and I'd like to move to the 2001 document from them, DHNI 5013, please, _065. We see this is January 2001, and if we turn to page 5, please, we read this as the introduction. 10 years ago, CREST issued guidance on the use and supply of blood products in Northern Ireland. Since then, there has been an increasing awareness of the need to use blood only when it is essential. In view of this changing environment, CREST decided to revisit its guidelines, and a small group of physicians, haematologists and transfusion medicine specialists was established to take this forward. So in other words, between the guidance we looked at earlier in the afternoon in 1989, this appears, and from our searches, we can't find anything else, this appears to be the next guidance provided in Northern Ireland in relation to blood transfusion. The guidance that is then provided is largely mirroring that in England and Scotland. In Scotland in 2002, the SNBTS published a leaflet for doctors and nurses about red cell transfusions. It reminds clinicians to consider whether each transfusion is truly necessary before ordering it. It gives guidance that red cell transfusion is rarely indicated in perioperative, post-operative and intensive care use when hemoglobin is above 8 and almost never when it is greater than 10. It states that with bone marrow failure, hemoglobin should be maintained at greater than 8, or if platelet support is needed and bleeding is a problem, then at greater than 10. Red cell transfusion is noted as only rarely necessary to treat iron and other hematinic deficiency. The need to keep clear records, including the reason for transfusion and what was given, is noted, as is the need to provide understandable basic information to patients about the transfusion. In 2003, the British Society for Haematology produced guidelines for the use of platelet transfusions, updated guidance. The lack of consensus with regard to prophylactic use of platelet transfusions was noted, and thresholds were identified for patients with bone marrow failure, chronic thrombocytopenia, and in massive transfusion. It's worth then noting that on the 31st of March 2004, an EU directive was enacted, coming into force in February 2005, requiring member states to ensure the traceability of blood from donor to the recipient and vice versa. Data required for full traceability was to be retained for a minimum of 30 years after clinical use. If we can then turn to another edition of the Handbook of Transfusion Medicine, RLIT 40812, please, and we'll turn straight to page 18. What we have here are what's called the Transfusion 10 Commandments, and it's number one is noted as transfusion should only be used when the benefits outweigh the risks and there are no appropriate alternatives. Results of laboratory tests are not the sole deciding factor for transfusion. Transfusion decisions should be based on clinical assessment, underpinned by evidence-based clinical guidelines. Not all anemic patients need transfusion. There is no universal transfusion trigger. Discuss the risks, benefits, and alternatives to transfusion with the patient and gain their consent. The reason for the transfusion should be documented, and then there is further matters of identification.
What date is this?
This is, apologies, I had it noted. 2013, so a relatively recent.
2013. So in 2013, there's an express reference to getting consent.
Indeed.
Is there an earlier one?
So I feared you were going to ask me that, and at this point in the afternoon, I think there was. I would need to just go back to the written presentation to confirm it. But it certainly wasn't until the 2000s, because we saw the documents in the 1990s that addressed no consent. I can certainly identify that for you. And then if we could turn on to page 44 of the handbook. We see in essentials, avoid unnecessary and inappropriate transfusions. And then the fifth bullet point, at every stage of the blood administration process, the key elements are positive patient identification, excellent communication, and good documentation. These can be enhanced by the use of electronic transfusion management systems and barcode technology. And then the next bullet point, hospitals should develop local transfusion policies based on national guidelines and ensure all staff involved in the clinical transfusion process are appropriately trained and competency assessed. And then if we turn to page 47, we see the heading documentation. The documentation required at each stage of the transfusion process should be kept to an essential minimum, and whether hard copy or electronic, be user-friendly to encourage compliance by busy clinical teams. Combined transfusion prescription and monitoring charts or care pathways can be used to record the information and provide a clear audit trail. The development of standardised transfusion documentation in the UK has the potential to reduce errors by clinical staff moving between hospitals. All transfusion documentation should include the minimum patient identifiers. And then we see in pre-transfusion, the requirements, the reason for the transfusion, the risks, benefits and alternatives to transfusion that have been discussed with the patient, and documentation of consent, the components to be transfused. And then during transfusion, the third bullet point, donation number of the blood component. And then if we turn the page, we have the heading patient consent. The Advisory Committee on the Safety of Blood, Tissues and Organs recommends that valid consent for blood transfusion should be obtained and documented in the clinical record. And so I suspect it's that set of minutes that I will provide to you to make sure we have the correct date. In November 2015, NICE published a guideline on blood transfusion, which recommended the use of red cell transfusions when hemoglobin was 7 grams per decilitre. Sometimes it's written as 70 grams per litre, but it's 7. And to use single unit red blood cell transfusions for adults without active bleeding. So we see a shift in the mid-2000s towards single unit transfusions, rather than the previous practice of avoiding them. And that's something that, so I think we'll pick up with some of the witnesses later this week. Platelet transfusions are recommended prophylactically for patients with platelet counts below 10 times 10 to the 9 who are not bleeding or having invasive procedures or surgery, excluding those with chronic bone marrow failure, autoimmune thrombocytopenia, heparin-induced thrombocytopenia, and thrombotic thrombocytopenia purpura. Then when we come to specialty-specific guidance, there was a plethora of guidance produced during the 2000s, and in a sense, the existence and the extent of that guidance may itself be of interest. Inevitably, I have selected a very small number just to give a broad overview of the position in the 2000s. In relation to anaesthesia, in 2001, the Association of Anesthetist of Great Britain and Ireland produced the document Blood Transfusion and the Anesthetist Red Cell Transfusion, recommending that anaesthetists should play a lead role in pre-operative assessment and preparation, and that the decision to transfuse should be on an individual patient basis, not to achieve a normal hemoglobin concentration. A permanent record of the administration of each unit of red blood cells should be kept. The use of blood ordering schedules and having an anaesthetic representative on the Hospital Transfusion Committee is also recommended. As to surgery, in October 2001, the Scottish Intercollegiate Guidelines Network produced a national clinical guideline on perioperative blood transfusion for elective surgery. The guidelines recommend that the provision of clear verbal and written information about the risks and benefits of allogenic blood transfusion is emphasised as good clinical practice. Whenever possible, alternatives to transfusion should be discussed with the patient in advance of need to allow arrangements for their delivery to be put in place. The guidelines note a wide variation of transfusion practice, which may be due to many factors, including differing opinions on the threshold level of hemoglobin for transfusion, differences in surgical and anaesthetic techniques, and differences in case mix. The guidelines recommendations include that pre-operative anemia should be corrected by, for example, iron therapy prior to major surgery to reduce exposure to allogenic transfusions. Intraoperatively, when there is ongoing surgical blood loss, hemoglobin measurements should be interpreted in the context of a multifaceted clinical assessment. And post-operatively, transfusion is unjustified at hemoglobin levels greater than 10 and is required at levels of less than 7, although for patients with cardiovascular disease or those expected to have covert cardiovascular disease, then it's noted that those patients are likely to benefit from transfusion when their hemoglobin level falls below 9. In obstetrics, the first edition of a guideline from the Royal College of Obstetricians and Gynecologists on blood transfusion in obstetrics was published in February 2007. And so the fact of that date for a first guideline from the Royal College in relation to blood transfusion is perhaps in itself significant. There were certainly guidelines in relation to obstetric transfusion from the haematologists, but in terms of the Royal College of Obstetricians, this is the first guideline that's been identified.
Yes, and obstetrics is really where modern practice of transfusion began, isn't it?
Indeed.
I think 1818 with Brundell. Right.
I bow to your superior knowledge on that, sir. I'm afraid I can't claim to know about that. But obstetrics certainly has been the guiding force, particularly in relation to massive blood loss and significant hemorrhage.
Yes.
So it's somewhat surprising, perhaps, that the first guideline on blood transfusion and obstetrics is published so late in the piece. The guidelines recommend that where major hemorrhage occurs, there are no firm criteria for initiating red cell transfusion, and the decision to do so should be made on clinical grounds. It says, nevertheless, that transfusion is rarely indicated in the stable patient when hemoglobin is greater than 9, and is almost always indicated when less than 4 to 5. Postnatally, where hemoglobin is between 7 and 10, and there is no ongoing or threat of bleeding, the decision to transfuse, quotes, should be made on an informed individual basis. In fit, healthy, asymptomatic patients, there is little evidence of the benefit of blood transfusion. In relation to haematology, the British Society produced guidelines on the management of acute myeloid leukemia in adults in 2006, which included the recommendation that there was no good evidence to support a particular red cell transfusion policy in AML, whereas platelet transfusions were recommended to support thrombocytopenia with a transfusion threshold of 10 times 10 to the 9, unless there were additional risk factors such as sepsis or concurrent use of antibiotics. With regard to sickle cell disease, guidelines on red cell transfusion in sickle cell disease were produced by the British Society in 2016. If we could turn them up, RLIT 40806, please. We can see that it says red cell transfusion has an important role in the management of sickle cell disease in both emergency and elective settings. The present guideline examines current available evidence on indications for transfusion in SCD. This may not be appropriate for all clinical scenarios, and clinical decisions must be based on individual patient considerations. In both guidelines, the term sickle cell disease refers to all genotypes of the disease, and sickle cell anemia to the homozygous state SS. And then under the heading Key Recommendations in the right-hand column, consideration of sickle cell patients for transfusion, particularly long-term regimens, should weigh up the potential benefits against potential risks. Cerebrovascular disease, regular transfusion to maintain HbS, sickle hemoglobin of less than 30%, should be offered as initial treatment to children with SS or SB thalassemia, age 2 to 16, judged to be at high risk for a first stroke on the basis of transcranial Doppler ultrasonography. Then if we turn the page, we see on the left-hand column long-term transfusion to maintain HbS less than 30% is recommended for the prevention of recurrent ischemic stroke due to sickle cell disease in both children and adults. Then further down under the heading of surgery, pre-operative transfusion is recommended for SC patients undergoing medium risk surgery. Indeed, pre-operative transfusion is recommended for SS patients undergoing medium risk surgery, abdominal tonsillectomy, orthopedic. Pre-operative transfusion is recommended for SC patients undergoing medium risk surgery. Transfusion is recommended for sickle cell patients of all genotypes requiring high risk surgery, e.g. cardiovascular, brain. And then further down, for patients requiring emergency surgery, sorry, Sally, we were just there. For patients requiring emergency surgery, the urgency and complexity of the procedure should be taken into account in the timing of perioperative transfusion. Simple transfusion should be given preoperatively if hemoglobin is less than 90 at 9, provided this will not result in undue delay to surgery. If transfusion is likely to cause an unacceptable delay to surgery, it is reasonable to proceed to surgery while arranging to transfuse the patient intra- or post-operatively if necessary. Acutely ill patients, transfusion is recommended and may be life-saving in acute sickle complications, such as splenic sequestration, hepatic sequestration, aplastic crisis, and severe acute chest syndrome. Transfusion should be considered in the unwell patient with acute multi-organ failure, mesenteric syndrome, and patients with severe sepsis. And discussion should be had with the specialist hemoglobinopathy team. In 2006, the British Society for Haematology produced updated guidelines in relation to massive blood loss, and that's something, so I anticipate addressing with one of the witnesses later in the week, so I'll simply note that it's there and we'll discuss the details of it with a witness. So I have one final part of this presentation. I'm very aware that we were due to be sitting tomorrow as well, but it's not a very significant section, so if I may, I'll continue for perhaps another...
Roughly how long do you think it will take?
I think about 20 minutes.
Well, shall we simply go ahead?
That was my instinct, sir. Thank you, I will.
It's better to do that than come back tomorrow for 20 minutes.
Absolutely. I just wanted to flag that we are on the final part and I don't expect to be very much longer than 20 minutes. So the final part of the presentation is to address the UK Chief Medical Officer's National Blood Transfusion Committee. On the 6th of July 1998, a symposium was held called the UK Chief Medical Officers Symposium on Evidence-Based Blood Transfusion. This laid the foundation for many of the subsequent guidelines that followed from 1998. As we've highlighted in the presentation, the late 1990s and through the 2000s, there was a significant increase in guidelines, and many of those can be pinned to the Chief Medical Officer's initiative of the National Blood Transfusion Committee. And it might be suggested that the initiative led to very significant changes in both attitudes and practices in relation to blood transfusion. So although it's rather late in the piece, it may give some insight into what is possible when a UK-wide approach is taken. Following the symposium, an interim National Blood Transfusion Committee was established with the aim of establishing a structure throughout the UK of hospital, regional, and then the National Transfusion Committee, and for that to be done by September 2001. Also following the symposium, a health service circular on better blood transfusion, dated the 11th of December 1998, was published. Could we put that on the screen, please, Sully? It's NHBT 20-83701_002, please. We can see the date at the top, and if we just go down slightly, we can see that it's for action by, and it's the health authorities of England, the chief executives, the directors of public health, and the finance directors, and then the NHS trusts, the medical schools, and the postgraduate deans. And if we turn the page, please. We see under the heading Summary, attention has focused on blood transfusion practice recently for several reasons. Greatly increased demand for blood compared with the increase in donations, the likely additional demand for blood associated with the waiting list initiative, the rise in the cost of blood with leukodepletion and nucleic acid testing, the recommendations from the Serious Hazards of Transfusion SHOT inquiry on how the safety of patients receiving blood could be improved, the theoretical risk of new variant VCJD, then the implications of clinical governance for blood transfusion practice. This circular details the action required of NHS trusts and clinicians to improve transfusion practice. And then if we go to the next page, please. We have the heading Hospital Transfusion Committees. Every NHS trust where blood is transfused should have an adequately resourced, multidisciplinary hospital transfusion committee. Some NHS trusts may share a committee, whilst others may need more than one. Given its key role in resource and risk management, the HTC should be an integral part of local arrangements for clinical governance, with corresponding lines of accountability to the Chief Executive. The structure and organisation of an HTC should be informed by the best practice of existing HTCs, and it should be in close contact with local and national blood user groups. About 65% of NHS trusts already have an HTC, and there is a wealth of knowledge about what works best. The National Blood Users Group is an excellent information resource. As a minimum, an HTC should promote best practice through local protocols on national guidelines, lead multi-professional audit of the use of blood components within the NHS Trust, focusing on specialities where demand is high, e.g. hemato-oncology and certain surgical specialities. Maintain a database that allows feedback on performance to all hospital staff involved in blood transfusion. Promote the education and training of all clinical and support staff involved in blood transfusion. Have the authority to modify existing blood transfusion protocols and to introduce appropriate changes to practice. Report regularly to local and through them to national blood user groups. Consult with local patient representative groups where appropriate, and contribute to the development of clinical governance. And then we see under the heading Transfusion Guidelines and Protocols, the use by clinicians in the NHS of red cells, platelets and fresh frozen plasma for the same procedures is highly variable. This suggests that some of these scarce resources are being used unnecessarily and could be better managed. This also has implications for patient safety. In general and in the field of blood transfusion, evidence-based clinical guidelines have been shown to improve clinical practice. Currently, however, most guidelines on blood transfusion practice come from expert committee reports and opinion, and although soundly based, may lack the rigour of well-controlled clinical trials. Therefore, whilst existing guidelines from the British Blood Transfusion Society and British Committee for Standards on Haematology and protocols based on them need to be encouraged and implemented, the development of evidence-based practice must be supported. Agreed hospital blood transfusion protocols should be on induction programmes for all clinical staff, be available in summary form in hospital handbooks and on the wards. Their implementation will require the support of the senior clinical nurse. Where there are gaps in knowledge, further systematic review of current work and research into transfusion practice are required. In Scotland, a management executive letter was circulated, and that is SCGV 5039_177. The letter was circulated on the 2nd of February 1999, and if we turn the page, we can see the action that was required. From March 1999, all NHS trusts where blood is transfused should ensure that hospital transfusion committees are in place to oversee all aspects of blood transfusion and should participate in the annual SHOT inquiry. By March 2000, all NHS trusts where blood is transfused should have agreed and disseminated local protocols for blood transfusion based on guidelines and best national practice and supported by in-house training, and have explored the feasibility of autologous blood transfusion and ensured that where appropriate, patients are aware of this option. In particular, they should have considered the introduction of perioperative cell salvage. A second second Chief Medical Officer conference was held on the 29th of October 2001. Prior to the conference, the purpose of the conference was established with the 4 UK CMOs, and it was this. Despite work over the last 3 years, local audits still suggest that the use of blood components remains highly variable between clinicians and hospitals and needed to be explored as a marker of surgical/clinical practice. Most importantly, and in the aftermath of the recent HCV ruling, the risk of blood transfusion would need to be recognised upfront and put in clear perspective for the public, patients and clinicians. The main issue, therefore, was about risk, scoping the risk of receiving blood components, risk against effectiveness, communicating this to patients and the service in the context of the benefits, and reducing the risk through best clinical practice. This approach would require a full and honest partnership between the blood services and the public. It would need to be based on an agreed recognition of the risks, a policy that did not promote blood transfusion as safe, and fully governed by informed consent. It said that the plain message was to be that we've come a long way since 1998. At that second conference, it was noted that an audit of the implementation of the 1998 circular showed that most hospitals had established hospital transfusion committees, had participated in the SHOT scheme, and had protocols for the administration of blood. However, there was also evidence of poor provision of training for clinical staff and patient information, few protocols for the appropriate use of blood, few audits of transfusion practice, and limited use of autologous transfusion. At the seminar, the establishment of the CMO's National Blood Transfusion Committee was also highlighted. It was hoped that the flow of information between hospital transfusion committees and regional transfusion committees and the CMO's National Blood Transfusion Committee should encourage good local blood transfusion practice and the implementation of national transfusion guidelines. One of the first initiatives of the National Blood Transfusion Committee was to undertake a national comparative audit in blood transfusion, one of the purposes of which was to enable comparative data between trusts to be used for the improvement of practice involving education and the development of achievable benchmarks. A further health service circular was published on the 4th of July 2002. It was focused on ensuring that better blood transfusion was an integral part of NHS care. Once again, it emphasised the need to have a hospital transfusion committee which would implement good transfusion practice, regular documented training for staff, the provision of timely written information about blood transfusion and its alternatives for patients, and having agreed and disseminated protocols for safe and effective transfusion practice, adopting national guidelines for the appropriate use of blood. In terms of progress that was made, I want to turn now to the second annual report of the National Blood Transfusion Committee from September 2004. RLIT 40852, please. We see towards the bottom of the page the heading Progress in the Implementation of the 2002 Circular. A questionnaire was issued to haematologists in charge of blood banks in April 2003. There was an overall response rate of only 47% of NHS hospitals. Progress since 2001 on the implementation of better blood transfusion in the NHS hospitals who responded to the questionnaire included greater participation in the SHOT scheme to 100%, an increase in hospital transfusion committees to 98%, an increase in hospital blood banks with accreditation to 86%, an increase in the number of hospitals with transfusion practitioners to 51%. Now, of course, one must recall that the response rate was only 47%, and those percentages are therefore of that 47%. And so I'm sure you recall the evidence that we heard about the SHOT scheme earlier, a few months, maybe a month ago, in terms of how it was set up and the challenges that were faced in the early days of getting hospitals to actually engage with it. This report does note, however, the lack of progress in the following areas: training of staff, the development of protocols for the appropriate use of blood, and the provision of information to patients. There was evidence of regional variation in the development of hospital transfusion teams. Then if we go over to page 3, please. National Comparative Audit. The National Audit of Transfusion Practice, in collaboration with the Royal College of Physicians Clinical Evaluation and Effectiveness Unit, revealed deficits in the practice of blood transfusion. And then it's the third bullet point. Record keeping was often poor, making it difficult to demonstrate that optimal care was given, and demonstrates lack of preparedness for the vein-to-vein approach to documenting blood transfusion practice as required in the EU directive. So even as in 2003-2004, there are ongoing difficulties noted about the traceability of blood transfusions. In September 2006, NHS Scotland published clinical standards on blood transfusion. These standards flowed from the UK CMO's conference. They include that the NHS board must have a system in place to ensure that every unit of blood component received into the hospital transfusion laboratory can be unmistakably traced to its recipient or to its final fate if not transfused. The decision to transfuse is made following consideration of the potential risks and benefits of, and the alternatives to, transfusion. Where possible, this is discussed between the clinician and patient, or their legal guardian, in advance of transfusion, and procedures are in place to optimise blood use and minimise wastage. In 2006, a review of the progress of the Better Blood Transfusion Initiative was produced, covering the period 1998 to 2006. It considered what was required to, quote, refocus and energise it. The report noted the progress and remaining gaps. It recorded that medical use was by then a significant user of red cells, whereas surgical use had reduced. There had also been little effect on the use of fresh frozen plasma and platelets. Audits, it said, indicate considerable inappropriate usage of these products, which should not also become a focus for reduction. The report noted some of the underlying reasons for the slower than ideal implementation, namely the lack of an effective means of enforcement by the CMO's National Blood Transfusion Committee, that appropriate use of blood was not high enough up on the hospital priority and risk management agendas, the lack of resourcing for hospital transfusion teams, and insufficient awareness/education within hospitals regarding the potential impact of blood shortages on patient safety. And those areas became the focus for the work of the National Blood Transfusion Committee. There were further health service circulars in 2007 and 2010, and the National Blood Transfusion Committees continued to operate, coming under the leadership of Dr. Wallace in October 2014. Later this week, the inquiry will be hearing evidence from Dr. Wallace and from Dr. Murphy, both of whom have been heavily involved in the Better Blood Transfusion Initiative. And it's anticipated that the ongoing work and the current position will be addressed with them rather than through this presentation. So that draws this presentation to a close, I think within my 20 minutes, perhaps, unless there's anything you'd like me to address further.
No, except I think you may have answered the question about the first reference to consent that is traceable, because you did tell me, I think, that in 2001, that there was a requirement or suggestion that there should be consented transfusion.
Thank you. Yes.
There may have been an earlier one, but at least it goes back in one of the official documents to 2001.
I will double check again that there's nothing earlier, but yes, I think it certainly appears in the 2001 CMO documentation.
Yes, so that concludes this presentation.
It does.
This presentation had originally been planned to go on tomorrow, as you may know. Obviously, it won't now because we've finished it. Tomorrow we will not be sitting, but we begin again on Wednesday.
We'll be hearing from Professor Philip Steer and Dr. David Bogot. Professor Steer is an obstetrician and Dr. Bogot is an obstetric anaesthetist.
So we hear them 10 o'clock on Wednesday. So till 10 o'clock on Wednesday, thank you.